Hello everyone, nice to meet you again. This is Mylin from the Respiratory department. Today, we will learn a new disease, respiratory failure. In Chinese, it's called 呼吸衰竭. In this class, we will learn about the introduction, clinical manifestation, auxiliary examinations, diagnosis, and treatment for the respiratory department. And finally, we will have a case discussion. Firstly, let's look at the definition of the respiratory failure. Respiratory failure is defined as a syndrome in which respiratory dysfunction results in abnormality of the oxygenation and or ventilation, leading to hypoxia and hypercapnia, and associated physiological disturbance and clinical manifestation. The diagnostic criteria for the respiratory failure are a partial pressure of the oxygen under 60 mm of mercury, with or without a partial pressure of the carbon dioxide over 50 mm of mercury under the condition of the some standard condition. So the definition is complicated, right? But we can try to pick out some keywords for us to understand it easily. Firstly, the respiratory failure is a syndrome. It's not a primary disease. It's a syndrome caused by different causes. That means lots of primary disease can finally result in a respiratory failure. Another keywords are the oxygenation, with or without ventilation. That means the mechanism of the respiratory failure is about the abnormalities of the oxygenation and or ventilation. And these mechanisms can finally result in a hypoxia and hypocapnia. We just talked about the diagnostic criteria for the respiratory failure, with a abnormal range of the partial pressure of the oxygen and carbon dioxide. But we need to notice here, there is a standard condition of room air breathing during rest at sea level of the altitude. And we also need to exclude other causes which can induce a blood gas abnormality. That's the keywords in the definition of the respiratory failure. And now, let's look at some more details about these keywords. Firstly, the respiratory failure is a syndrome due to the primary disease. The mechanism of respiratory failure is about the abnormalities of oxygenation and or ventilation. The abnormality of oxygenation usually results in the type 1 respiratory failure. And the abnormality of ventilation usually results in type 2 respiratory failure. Hypoxia is required for the respiratory failure, but the hypercapnia is related to the types of the respiratory failure. And finally, the symptoms and signs are associated to the hypoxia and hypercapnia. That's the key points in the definition of the respiratory failure. Now, let's look at the pathogenesis of the respiratory failure. How did the respiratory failure occur, and why are they divided into two types? This picture stimulates the process of the oxygen into the body and the carbon dioxide out of the body. Let's look at here. This card shows the oxygen into the alveolar and the carbon dioxide out of the alveolar. It presents the ventilation of the gas. This area shows the blood-air barrier, which formed by the alveolar cells, basement membrane, connective tissue in the interstitium, and vessel wall. And this shape shows the ion exchange passing through the blood-air barrier. And here shows the diffusion rate of the carbon dioxide is higher than that of the oxygen. And now, let's look at the mechanism of the respiratory failure. There are three mechanisms can induce a respiratory failure. The first one is decreased ventilation. It usually results in hypoxia with a retention of the carbon dioxide. Let's look at here. Here shows the normal condition. But when the ventilation decreasing, we can find the cars decreased. So, less oxygen can be transmitted into the body and less carbon dioxide can be expelled out of the body. That's the hypoxia and retention of the carbon dioxide. The second mechanism of the respiratory failure is the decreased oxygenation. It usually occurs in the disease with a extended diffusion distance. In this condition, the same quantity of the carbon dioxide can be expelled out of the body because of its high diffusion rate, but less oxygen can enter the body during a certain time because of its low diffusion rate. So, in this condition, this patient usually called a hypoxia, but without retention of the carbon dioxide. The third mechanism for the respiratory failure is the VQ ratio imbalance. In this condition, this patient usually with a hypoxia predominantly, but rare with a retention of the carbon dioxide. According to the pathogenesis, we can try to confirm the causes of the respiratory failure. But there are too many causes of the respiratory failure in your textbook, right? It's important but complicated. And now we can try to find some methods to do a summary for them. And that will help us to remember them. Firstly, let's think about this question. How many steps are there in an integrated respiration? Okay. Respiration usually includes external respiration and internal respiration. An integrated respiration usually includes several steps. Firstly, the respiratory center gives out commands of the respiration. And where is the respiratory center? This question is left for you, and I hope you can give me the answer in the question and answer session. Okay? And next, the nervous impulse was transmitted to the muscles, which can result in the movement of the respiratory muscles. In this condition, there will be a negative pressure in the thorax, and it will cause the air in and out of the body. That's the air ventilation. Once the gas into the alveolar, there will be a gas exchange in the alveolar. The oxygen can diffuse into the blood, and the carbon dioxide will diffuse out of the blood and into the alveolar. That's the gas exchange. And next, the gas can be transported to all over the body. That's the gas transportation with blood. And finally, the tissues and organs can consume oxygen and produce carbon dioxide. That's the internal respiration. And the carbon dioxide can also be expelled out of the body with the gas transportation, gas exchange, and finally the ventilation. So that's an integrated respiration. Now, let's try to do a summary for the causes of the respiratory failure according to the abnormalities in each steps of the respiration. Firstly, for the respiratory center, if there is a damage of the respiratory center, it will cause a decreased ventilation. The causes include cerebral infarction or hemorrhage of the respiratory center directly, or the cerebral hernia caused by the massive cerebral infarction or hemorrhage. All of these causes can cause apnea, which can finally with a decreased ventilation. If the respiratory center is alright, the abnormality of the respiratory muscles can also induce a decreased ventilation, such as the myasthenia gravis and other nervous and muscular disease. Sometimes the massive pleural effusion or pneumothorax can also influence the constriction of the respiratory muscles, which can result in the decreased ventilation. If the respiratory center and respiratory muscles are normal, once there is an obstruction of the airway, it will cause the decreased ventilation too. The obstruction can occur in large airway, such as the foreign body and tumor, and also occurs in small airway, such as the COPD and asthma. Both of these obstructions can result in a decreased ventilation. If the ventilation is normal, the abnormality of the gas exchange can induce a type 1 of the respiratory failure, such as the interstitial disease, ARDS, pulmonary edema, and so on. If the gas exchange is normal, and there is some abnormalities in the gas transportation with blood, it can also cause an abnormality in the artery blood gas analysis, such as the pulmonary embolism, shows the abnormalities in the pulmonary circulation. The cardiac shunt or arterial venous shunt can also show the abnormality of the systematic circulation. If the gas transportation is normal and the blood reach the tissue or organs, the abnormally increased consumption of the oxygen can also induce a significant decreased partial pressure of the oxygen, such as the surgery. Here please notice that the disease in blue are the causes of the respiratory failure, and the disease in the gray are the differentiated diagnosis for the respiratory failure. And that's the disease due to the abnormalities in the arterial blood gas analysis. I hope that you can try to do the summary by yourself for other causes of the respiratory failure, and you can remember them easily. Now let's look at the classification for the respiratory failure. There are several methods for the classification, but I would like to tell you the most popular two methods of the classification for the respiratory failure. The first one is according to the cause. The second one is according to the mechanism. Let's look at the first one. According to the cause, they can be divided into acute respiratory failure caused by the acute disease and chronic respiratory failure, which caused by the chronic disease. According to the mechanisms of the respiratory failure, they can be divided into type 1 respiratory failure and type 2 respiratory failure. The type 1 respiratory failure is caused by the abnormality of the oxygenation, and the type 2 respiratory failure usually caused by the abnormality of the ventilation. Now, think about this question. Which method do you think is important for us? A or B or both? Okay, the answer to this question is both. And now, let's think about another question. Why are they important? And what's the meaning of this classification? Let's look at them one by one. About the acute disease, which can result in the acute respiratory failure. The typical disease is choke by foreign body, right? So, for this patient with acute disease, we need to remove the cause rapidly, and is the most important and useful treatment for this patient. If we cannot remove the cause rapidly, and it will cause a severe hypoxia injury of the organs, and the patient are likely to die, right? So, the principle of the treatment for this patient is rapid therapy, right? But for the chronic disease, which can cause the chronic respiratory failure, the typical disease include COPD or asthma, right? For this patient, we can know that they need long-term therapy for the cause, but not a rapid therapy for the cause. And we know that the chronic respiratory failure exists for a long time. So we need to do some prevention of the comorbidities which caused by this chronic respiratory failure. And the principle of the treatment for this patient is a long-term therapy and prevention. So the principle for these two groups of the patients are different, right? And about the different mechanisms, we can know that the type 1 respiratory failure usually caused by the abnormality of the oxygenation. So it means oxygen therapy is useful. But for the type 2 respiratory failure, the mechanism is usually about the decreased ventilation with a retention of the carbon dioxide. So for this patient, the oxygen therapy is not work, because the oxygen therapy cannot decrease the level of the carbon dioxide. In this condition, this patient needs a mechanical ventilation, or sometimes they need the bronchodilators to increase the ventilation. So, according to the mechanisms, the therapy is different from these two groups of the respiratory failure. And that's why both of them are important for us. Now, let's move to the clinical manifestations. The same to the copamnol. The respiratory center is a secondary center, which caused by the primary disease. So, the symptoms and signs can also be divided into different groups. Firstly, the symptoms can be divided into two groups. The first group of the symptoms are caused by the respiratory failure, that is, caused by the hypoxia and hypercapnia. The symptoms include dyspnea, symptoms of hystanoxia, such as the dizzy coma, which shows the hypoxia of the brain, and angina, which shows the hypoxia of the cardiac muscle cells. And finally, the compensatory response, including the tachypnea, palpitation, and so on. The second group of the symptoms are called combining symptoms, which are associated to the cause. For example, if the respiratory failure is caused by the cerebral infarction, We can also find the symptoms of hemoparalysis, anesthesia, or coma in the patient. And if the patient got a respiratory failure caused by the COPD, they are likely to get cough, sputum, and dyspnea at the same time. If the respiratory failure is caused by the pulmonary embolism, we usually can find the chest pain, dyspnea, or hemoptysis in these patients, and so on. So, once we collect the information of the symptoms from the patients, we need to identify and analyze the suspected reasons of the symptoms. That's the symptoms of the respiratory failure. About the signs, they can also be divided into two groups. The first group is caused by the respiratory failure. For the patients with hypoxia, we usually can find coma in the patients with severe hypoxia, cyanosis in the lips or fingers, 3D pressure sign. This picture shows the 3D pressure sign, including the suprasternal fossa, supraclavicular fossa, and intercostal space. Tachycardia. Finger cramping for the patients with a long-term hypoxia. About the hypercapnia, we usually can find the chemosis. Let's look at this picture. What can we find from this picture? Yes, we can find the eyes of this patient is red and with some tears, right? It looks like this patient just cried. That is the chemosis, which present the extension of the capillaries in the eyes and face, which caused by the irritation of the carbon dioxide. We can also find the skin flushing hypoxic injury. And finally, others including the abnormal rhythm of the respiration, such as the Bell's breathing, Kazma breathing, and so on. That's the first group of the signs which caused by the respiratory failure directly. Another group of the signs are caused by the causes of the respiratory failure, that is the primary disease. We usually can find positive signs from the physical examination of the respiratory system, cardiovascular system, and nervous system. For example, for the patients with myasthenia gravis, we usually can find the muscle weakness during the physical examination. And if the respiratory failure is caused by the COPD, we usually can find the barrel chest, vocal parameters decreasing, decreased breath sound, wheezing rails, and so on during the physical examination of the respiratory system. And that's the second group of the signs, the combining signs caused by the causes. Now, let's move to the auxiliary examinations. The ABG, arterial blood gas analysis, is the most important examinations for the patients with a suspected respiratory failure. And let's look at it firstly. This table shows some important items of the ABG. You have learned in the course of the diagnosis, right? So, I hope you can review the normal range and meaning of each item of the ABG by yourself after class, okay? And there are 4 approaches for the sample of the arterial blood. The most useful one is through the radial artery. And sometimes we can also use other 3 approaches, including the arteries in the elbow, femoral artery, and the dorsopedal artery here. How to read the report of ABG? In China, there is a very special method to read the report of ABG. It's called ABG analysis in 6 steps. 血气分析6步法 But it's too complicated. And now I will show you the most important 3 steps in that method of the analysis. The first step, to confirm with or without respiratory failure. We can look at the level of the partial pressure of the oxygen and the partial pressure of the carbon dioxide. Step 2, to confirm the existence of the acidosis or alkalosis with the data of pH. And step 3, to confirm the respiratory or metabolic acid-base imbalance, as this table showing. If there is a single increased partial pressure of the carbon dioxide, we can conclude a respiratory acidosis. And if there is a single decrease of the partial pressure of the carbon dioxide, we can conclude a respiratory alkalosis. And the data of BE and SB is associated to the metabolic acid-base imbalance. And if we find abnormal changes in all of the partial pressure of the carbon dioxide, BE and SB, at the same time, there will be a mixed acid-base disorder. In this condition, we need some formulas to confirm how many acid-base disorders are there. And that's the 3 steps to read the report of the ABG. If you are interested in the ABG analysis in 6 steps, you can try to search online with Chinese after class for your further self-learning. After we read the report of ABG, we can confirm whether there is a respiratory failure or not, according to the diagnostic criteria of respiratory failure. That is type 1 respiratory failure with the partial pressure of the oxygen less than 60 millimeter of mercury, with the normal or decreased partial pressure of the carbon dioxide. And the type 2 respiratory failure is with a partial pressure of the oxygen under the 60 millimeter of the mercury, with a partial pressure of the carbon dioxide over 50 millimeter of mercury. The differences between the type 1 and type 2 respiratory failure is about the level of the partial pressure of the carbon dioxide. And now, please think about this question. What's the standard condition for ABG? The standard condition include in rest, at sea level, or with 1 atmospheric pressure. Without oxygen therapy, that means with air inspiration. And that's the standard condition for ABG. Now think about another question. What's the meaning of standard condition for ABG? It's a very important condition for ABG. Firstly, let's look at some special case analysis. The first case is about a COPD patient. After admission to hospital, this patient received oxygen therapy because of severe dyspnea. In that condition, we arranged an ABG analysis for this patient, and the report of the ABG present partial pressure of the oxygen is 72 mm of mercury, and the partial pressure of the carbon dioxide is 65 mm of mercury. According to these items of ABG, what can we conclude? I will give you 4 answers. A. Type 1 respiratory failure. B. Type 2 respiratory failure. C. No respiratory failure. And D. Cannot confirm. What's your answer? Okay, the answer to this question is type 2 respiratory failure, and later I will tell you why. Let's look at another special case. It's for a patient with fever and swearing. In this condition, we arranged ABG for this patient to get a result of partial pressure of the oxygen is 58 mm of mercury and a slight decrease of partial pressure of the carbon dioxide. According to this report of ABG, what can we conclude? I also give you 4 answers. A. Type 1 respiratory failure. B. Type 2. C. No respiratory failure. And D. Cannot confirm. What's your answer? Okay, the answer to this case is cannot confirm the respiratory failure. We cannot confirm a type 1 respiratory failure because these patients are not in a standard condition with fever and swearing, which can increase the consumption of the oxygen and shows a decreased partial pressure of the oxygen. But we need to retest ABG when the swearing ends. That's the second case. And think about the third case. Here shows a pneumonia patient with well condition, no dyspnea, and partial pressure of the carbon dioxide is 43 mm of mercury. The oxygen saturation in artery blood is 67%, but the oxygen saturation in the finger wings, which means the non-invasive oxygen saturation, present 97%. In this condition, what can we conclude? The same for choice to another two cases. What's your answer? Yeah, the answer to this case is have taken venous blood by mistake. We need to retest ABG later. Why we can conclude a mistake? Please look at here. The oxygen saturation in artery blood or in the finger wings are different, right? Why are they different? And look at here. The pulse pressure of the blood is 48 millimeter of mercury. It's very low. It's a very low level. But this patient with a viral condition and with no dyspnea, that means there must be something wrong with this test. So, in this condition, we can conclude that this patient maybe have taken venous blood by mistake. But we need to retest the ABG later to confirm our conclusion. So, according to these three special cases, we can find that the pulse pressure of the oxygen under 60 millimeter of mercury is the criteria of respiratory failure only under the standard state. And the pulse pressure of the carbon dioxide over 50 millimeter of mercury is the criteria of type 1 or type 2 respiratory failure. Okay, for now, I think maybe some students have a question for me. For the case 1, the patient do not under the standard state. How can we conclude a type 2 respiratory failure for this patient? And whether there is a accurate diagnostic criteria for the patients do not under the standard state. Okay, the answer to the second question is that there is another diagnostic criteria for this patient without under the standard state. That is the oxygenation index. What's the oxygenation index and its meaning? The oxygenation index is a ratio of pulse pressure of the oxygen to the fraction of the inspelled oxygen. The normal range of the index is over 400. Once the index less than 700, we can conclude a respiratory failure. Now, let's look at some cases. The first case is about a normal person with the pulse pressure of 84 millimeter of mercury. The second case shows a COPD patient in standard condition with a pulse pressure of 60 millimeter of mercury. The third case is for a severe pneumonia patient after mechanical ventilation. The fraction of inhaled oxygen is 40%, and the pulse pressure for this patient is 80 mm of mercury. The fourth case is about a COPD patient after oxygen therapy. We just talked about this case before, and the partial pressure of the oxygen is 72 mm of mercury. According to the level of the partial pressure of oxygen, which patient are in the best condition and which patient are in the worst condition. According to the level of the partial pressure of oxygen, we can find that case 1 is in the best condition with a normal range of oxygen, and case 2 is in the worst condition because of the lowest level of the oxygen, right? But once we consider about the fraction of the inhaled oxygen and work out the oxygenation index for each case, does the answer change? Okay, let's look at the oxygenation index for each case. We can find that the case 1 is also in the best condition because of the normal oxygenation index. But the case 3 is in the worst condition because of the lowest level of the oxygenation index. So, the oxygenation index is a corrected criterion of the respiratory failure for the patients under no standard condition. And now, let's look back to the first case analysis and try to do an integrated case analysis. This COPD patient received oxygen therapy after admission to the hospital. And in this condition, we arranged ABG for this patient, which present pH 7.22. Partial pressure of the oxygen is 72 mm of mercury. Partial pressure of the carbon dioxide is 67 mm of mercury. Oxygen saturation is 93% and the BE is 5.6. According to the 3 steps of the diagnosis for the report of ABG, we can try to do the case analysis. Step 1, with or without respiratory failure. We can find that even though the partial pressure of the oxygen is over 16 mm of mercury, but the oxygenation index is less than 300, and the partial pressure of the carbon dioxide is over 50 mm of mercury. In this condition, we can conclude a type 2 respiratory failure for this patient. That's the step 1. Step 2, with or without acid-base imbalance. We can find that the pH is less than 7.35, which shows the acidosis. So, we can conclude that there must be an acidosis. And step 3, which type of the acid-base imbalance? We can know that the partial pressure of the carbon dioxide is significantly increased, which shows a respiratory acidosis. But the BE also increased too, which shows a metabolic acidosis. In this condition, we can conclude a respiratory acidosis plus a metabolic acidosis. That's the integrated analysis for an ABG report. Other abnormal findings can be divided into two groups. The first group is associated to the comorbidities which caused by the hypoxic injury of organs. For example, we usually can find an increased CKMB or TNT because of the hypoxic injury in heart. For the liver, we usually can find an increased ALT and AST. Kidneys, blood, pulmonary hypertension, and copulmonary, and others. All of these are associated to a short-term or long-term hypoxia. Another group of other abnormal findings is about the causes of the respiratory failure. For example, for the patients with a suspicion of the cerebral infarction, we need to arrange brain MRI or CT scan for this patient to confirm the causes. And the spirometer for the COPD, D-dimer or CTPA for the pulmonary embolism, CT scan or bronchoscopy for the foreign bodies in the airway, and others. And now, let's look at the diagnostic steps for a patient with respiratory failure. Firstly, to confirm the respiratory failure. And next, to confirm the cause of the respiratory failure. Finally, do not neglect to search for the comorbidities. Let's look at the first step. To confirm the respiratory failure. Once the patient comes to our clinical room or department, we can find some clues of the respiratory failure during the inquisition or physical examination. If the patient got a symptom of dyspnea and the symptoms about other causes, during the signs, maybe we can find the cyanosis shows a hypoxia, and sometimes we can find the chemosis, which caused by the retention of the carbon dioxide, and other signs about the cause. We can suspect a respiratory failure and the suspicion of the primary disease. Next, from the report of the ABG, we need to figure out that whether there is a respiratory failure or not. Which type does the patient belong to, type 1 or type 2 respiratory failure? And is there an acute or chronic respiratory failure? And finally, whether there is an acid-base imbalance or not. That's the first step to confirm the respiratory failure. Step 2, to confirm the primary disease of the respiratory failure. For example, if the patient is with a suspicion of the cerebral infarction, they need a brain MRI or CT scan For the diagnosis of the primary disease, the electromyography is required for the patients with a suspicion of the myasthenia gravis, and the spirometer for the COPD, D-dimer and CTPA for the pulmonary embolism, and so on. That's the step 2, to confirm the primary disease for the respiratory failure. In this step, we also need to do some differential diagnosis, including the cardiac shunt or pulmonary artery venous shunt, low cardiac output, Shiri, and other disease which can also induce abnormal changes in the ABG test. But we cannot diagnose a respiratory failure. Here please notice that respiratory failure is a syndrome or a function diagnosis. So, once we diagnose a respiratory failure, the primary disease of the respiratory failure must go first. That's the step 2. And step 3, to search for the comorbidities, including the hypoxic injury of the organs, copulmonale caused by the acute or chronic respiratory failure, acid-base and electrolyte imbalance, and other comorbidities. Now, let's move to the treatment. The approaches of the treatment for the patients with respiratory failure is the same to other disease we just talked about before. There are also 3 parts. Part 1, treatment for the cause. That is the treatment for the primary disease of the respiratory failure. Part 2, treatment for the symptoms. That is the treatment for the respiratory failure. Step 3, treatment for the comorbidities. Firstly, let's look at the first part, treatment for the primary disease. For example, if the cause of the respiratory failure is the cerebral infection, we need antiplatelet therapy and agents to regulate blood lipids. The glucocorticoids is required for the myasthenia gravis. Bronchodilators, glucocorticoids, appropriate antibiotics, and other therapy are required for the patients with COPD. Anticoagulant therapy for the pulmonary embolism, and so on. That's the first part of the treatment for the primary disease. The second part of the treatment is for the respiratory failure. Firstly, we need to make sure to keep the airway open, including the sputum drainage, to take care of the foreign body, and sometimes they need intubation. It's very important for the patients with acute respiratory failure and for some cases of the chronic respiratory failure. And next, to provide oxygen therapy with nasal duct or mask. Here please notice that for the type 2 respiratory failure, we cannot provide oxygen therapy with mask. In this condition, the carbon dioxide can be inhaled into the lungs, and the level of the carbon dioxide in the blood will increase. In this condition, this patient may be got a more severe type 2 respiratory failure. So, for the patients with type 2 respiratory failure, we cannot provide oxygen therapy with mask, but only with a nasal duct. But for the patient with type 1 respiratory failure, we can provide oxygen therapy with both nasal duct or mask. And next, do not neglect the CPR, especially for the patient with acute respiratory arrest in and out of the hospital. For the patients with severe respiratory failure, we also can consider to provide mechanical ventilation. There are two kinds of the mechanical ventilation: non-invasive or invasive. Now, let's look at some more details about the mechanical ventilation. For the non-invasive mechanical ventilation, we need to focus on the indication, constraint indication, and adverse reaction of the mechanical ventilation. This part is for your self-learning after class. This picture shows a non-invasive mechanical ventilation, and this is the ventilator. And there are two kinds of the mask. One is the face mask, with the mask cover the mouth and nose together. Another one is the nasal mask, only cover the nose of the patient. For the invasive mechanical ventilation, we also need to focus on the indication, contraindication, and adverse reaction of the invasive mechanical ventilation. This picture shows an invasive mechanical ventilation. We can find that this patient got an intubation. And this is the ventilator. There are 3 types for the intubation. The first one is the oral tracheal intubation. The tube is intubated into the trachea through the mouth. And this method of the intubation is the easiest one. So, we usually use this method of the intubation for the patient with emergency. But the patient can only keep this tube for 1 week or less than half a month. And sometimes, some patients will need intubation for a long time. In this condition, we need to consider other 2 methods of the intubation. The second method of the intubation is the nasotracheal intubation. The tube is intubated into the trachea through the nose. This method of the intubation is much more difficult than the first one, but the patient can keep this tube for 1 month. The third method of the intubation is the tracheotomy. As the picture showing, we do an incision of the trachea under the thyroid cartilage, and the tube is intubated into the trachea directly through this incision. This method is invasive. Patients can keep this tube for 1 month, and it's easy for us to change the tubes regularly. So, we usually use this method for the patients with severe nervous disease, such as the hemoparalysis caused by the cerebral infarction and so on. Part 3. Treatment for the comorbidities, including the treatment for the hypoxic injury of organ, such as the PPI for the digestive ulcer, diuretics for the carpal to enhance ventilation for the respiratory acidosis and so on. That's the systematic treatment for the patient with respiratory failure. Now, let's do a summary for this class. In this class, you need to master the main symptoms and main signs of the respiratory failure, the items of the ABG and their meanings, how to analyze the report of the ABG, and the diagnostic criteria for the respiratory failure. Here shows the self-learning for your homework. Okay, that's all for this class today. Thank you.